All right, so I'm pleased to actually, my name is Linda Bopin. I'm from Roswell Park Cancer Institute in Buffalo, New York, and I'm pleased to moderate this next session. And I think it's a great session to kind of start the afternoon part of today. The morning has gone so well. So we're going to start with session 3, Treatment and Survivorship Care Planning for AYA Patients. And we're going to start off with Kevin Oeffinger, who's going to talk about long-term and late effects following AYA cancer.
Thank you so much, Linda, and Patty and the group for organizing this. So just by way of background, listening this morning, this is my day at work. The program that I direct on our clinical side at Memorial Sloan Kettering, we follow a little over 1,000 patients that had their first primary cancer prior to the age of 40. About 80% of them had it between the ages of 15 and 39. And these patients now extend all the way up into their 70s, and we even actually have a few 80-year-old patients. And they're all at high risk, so it's largely population as we were describing earlier. So it's interesting to hear a lot of the comments. Let me start by actually describing a couple of terms that we sometimes use a little bit loosely and are not precisely defined, nor can we precisely define them. Long-term and late effects. Long-term is intended to mean a toxicity or a late effect that develops during the cancer therapy and then persists afterwards. So think of somebody that has renal insufficiency that's diagnosed on their therapy, they finish their therapy, and then it persists for years afterwards. Or you may have a late effect that shows up a year later, or 10 years later, or 15 years later. And sometimes the distinction between those two blur. Neurocognitive dysfunction. Sometimes it's not apparent. You know it actually started during therapy, but then it only becomes apparent maybe 3, 6, 12, 15 months later. We also throw around a lot of terms saying, well, that's a late effect. He has hypertension after his testicular cancer, and that's simply a late effect. And when we look at late effects, it's really in comparison to some non-cancer population or some other therapy if we're looking at the difference between them. And so we use terms such as relative risk, and much of my early work has been done in childhood cancers, and the relative risk can be quite high. In fact, the very first paper that was published on breast cancer following pediatric Hodgkin lymphoma showed a relative risk of 113, and that's much higher. It's really around 35 to 60 or so, much higher simply because small sample size, and it was a rare outcome, or radiation-related sarcomas, the same sort of thing. And so over time, we have evolved to also making sure that we report on absolute excess risk, and that is not only comparing that person to the same age individual, but also the number of events that are based upon that particular cancer or that exposure that you would expect in a certain population size. Or attributable risk, the amount of whatever percentage of that late effect that you might attribute to a certain exposure. And I'm going to highlight in a little bit a paper that's must reading for everybody in here that Melissa published in JAMA a couple of weeks ago that talks about the St. Jude Life and the childhood cancers, the late effects that we're seeing in that population. But it's a nice job in the statistical analysis that talks about attributable risk. So another term that we throw around is comorbidities. He has hypertension, he has lipid abnormalities, he has insulin resistance. Are those comorbidities? Are they late effects? Where is the difference between those? What's the distinction? And that's why you'll see a lot of times in our literature, we've actually used the term chronic health conditions, not attributing it, and then we'll show the excess risk as we talk about it, but using a more generic term of really focusing on the burden of morbidity that our cancer survivors live through. And I'm referring both to physical and, as Brad wonderfully presented earlier, a lot of the psychosocial late effects that we see. This is, pardon me, Archie, this is the 15 to 29-year-old figure. It has prettier colors, and I couldn't find a 15 to 39 easily. But it shows you the distribution of the adolescent and young adult cancers. It's a very heterogeneous population. And I'll use that as I walk through several of the different examples that I'm going to present in a moment. This is a wonderful slide that Melissa Hudson developed several years ago and then published in Cancer in 2005. I think it's a nice starting point to think about what are the factors that lead to somebody having an excess risk of a late effect. Some of these patients have a premorbid condition. They might have pre-existing hypertension or lipid abnormalities or whatever. The key premorbid condition to keep in mind is as we have this obesity epidemic roaring through our country, many of our patients are coming into therapy already obese, already having excess fat free mass, and then how that will affect their different health conditions over time. Genetics are not only important for predicting the first cancer, but they're also quite important in predicting second subsequent cancers, and I'll mention that in a moment. Tumor factors, where the tumor is located, its response. Of course, treatment exposures. That is the key component. Did they have radiation? What was filled? What was the dose? Did they have chemotherapy? What was a combination? Surgery, things of that nature. Sometimes treatment events play a role. Somebody has a seizure disorder. They had cranial radiation. What's going to be their likelihood of having future events? Host factors play a big role. In many of the AYA cancers, women have a disproportionate higher risk than men given the same therapies. Health behaviors, needless to say. I was absolutely shocked seeing that 25% smoking rate earlier. And that's certainly an area where we can make a difference. And we know so well that smoking potentiates most of the problems that we see related to cancer therapy, but many other health behaviors. And then another area that is receiving increased attention is aging. And I don't mean just our geriatric or elderly population, but our cancer survivors across the continuum. Does what happened to them during their therapy accelerate the aging process? Do they lose organ reserve such that for the next 10, 15, 20 years it's really inconsequential, but as they develop their normal aging-related problems, how does that affect them? This is an intentionally busy slide. If I talked about long-term and late effects, we could spend 2 or 3 hours going over them. And so this is just a whole host walking you through different examples, going from some of the cardiac problems we see, myocardial infarction, congestive heart failure, our second cancers, again, our psychosocial outcomes, a whole host of problems. So do we have any estimates of morbidity of the AYA population? The answer is no. We have reasonable estimates for certain diseases among testicular cancer survivors, among Hodgkin lymphoma survivors. Those are the two most studied population, a little bit more hit and miss. We often will use some of the data that we have from the Childhood Cancer Survivor Study, and I'll remind you that this is actually patients that were diagnosed age 0 or 1 month up to their 21st birthday. So that's the big chunk of A right there, and can be quite informative. And what we've also learned is that age at diagnosis doesn't really predict their overall morbidity. It predicts specific problems, but there's always a trade-off. Sometimes the older patient is a little bit higher risk, sometimes the younger is, but when you look at the overall morbidity, it doesn't. This is data that we published from the New England, Childhood Cancer Survivor Study in New England Journal a few years ago, and showed that 3/4 of patients by the time they were 30 years out from their cancer. So if you're diagnosed at age 10, by the time you're age 40, have at least one chronic condition, and 42% with a severe or life-threatening chronic condition or death from a chronic condition. This is the paper I mentioned a moment ago. It's just must reading. It's both methodologically wonderful, but also shows us what we can learn through screening. So in this study, Melissa and her colleagues at St. Jude applied the Children's Oncology Group guidelines to patients that they brought in. And they report both those chronic conditions that were diagnosed prior to their visit, those that were diagnosed as part of it, and then those subsequently. And a large population, and they were able to estimate by age 45, if you thought my estimates were high, look at that, 95% of the patients with at least one chronic condition, and 80% with a grade 3, which is a severe, or grade 4, I'm sorry, grade 3 is a moderate, grade 3 is a severe, 4 is life-threatening or disabling. So major outcomes. let me walk back to the slide from the childhood cancer survivor study I mentioned a moment ago. We see sometimes that the morbidity is very evident early on. Here's a good example. You can think of your adolescent and young adult medulloblastoma patients, which we follow a lot of those types of patients at Sloan Kettering. Their endocrinopathies are often apparent early on, or some of the neurocognitive changes. But our Hodgkin lymphoma population often starts with very little morbidity at the end of treatment, and then rapidly increases as they develop their second, third, fourth cancers. Many of the Hodgkin lymphoma patients that we have followed, I think we have 16% of the patients we follow in our program have had 3 or more major primaries. So that's just a quick give you an idea of an estimate, and we don't have, again, a young adult estimate for the full population of this very heterogeneous cancer group. So what I decided to do is I'm pull out 4 examples. I'm going to start with testicular cancer and then talk about breast cancer following a Hodgkin lymphoma patient treated during the adolescent or young adult years, talk a little bit about infertility, and this leads into some of the things that Jennifer will talk about later, and then talk about our allogeneic stem cell transplant recipients with multiple morbidities. So again, I bring you back to that figure from the monograph that NCI produced on 15 to 29-year-olds. And if I think of patients that are at risk for cardiovascular disease, coronary artery disease, congestive heart failure, valvular disorders, our lymphoma patients are at high risk by the time they're 20 years off therapy, regardless of the age at which they were treated. Roughly 13% of the patients have already had a myocardial infarction after mediastinal radiation. The risk of heart failure also has increased. We know that our patients that have had testicular cancer have a higher risk of cardiovascular disease. I'm going to go into that in detail in a moment. Our patients that have brain tumor survivors have metabolic disturbances that increase their risk of both cardiac disease and also of strokes. Our patients with leukemia, their high-dose anthracyclines, whether or not they got transplanted. Our young women that are treated with adjuvant chemotherapy with doxorubicin-based regimens and with or without trastuzumab affects their cardiac risk long term. And then, of course, our osteosarcoma and our Ewing sarcoma patients that are diagnosed in their late teens or into their 20s and 30s, and our soft tissue sarcoma patients. So you see here, I've circled actually a fairly large population of AYA, depending upon their treatment exposure, depending upon their specific factors, are at risk for cardiovascular disease. So let's talk about the male germ cell tumor survivors. I'm going to show you 4 studies that are all population-based, and after listening to our discussion, and I know many of us have been frustrated with our inability to do really good linkage analysis here, we have a colleague from the Netherlands visiting with us, Janine Nuver, and she's been involved in some of the other studies that I'll show you, but you have such a rich ability to be able to tap into it. As a sideline, the United Kingdom has a wonderful AYA study that using a linked database led by Michael Hawkins that's in process. So that'll give us some much better information that gives us some more global estimates of morbidity. But here's one by Sophie Foss and her group in Norway, where they reported on patients treated a fair time ago the increased risk for circulatory deaths, including myocardial infarction. And they didn't see a difference between whether or not cisplatin was introduced, and I'm going to talk about cisplatin a bit more. Here is Janine's group in the Holland looking at cardiovascular disease after platinum, and you see a hazard ratio of 1.7, and median survival after the cardiovascular disease was actually short. Here's a study by the United Kingdom. Again, you see you're moving your eras a little bit closer to contemporary time. And early on, you had mediastinal radiation that were used before you really had the introduction of cisplatin. And then in the later years, in the late 70s on in the early 80s, you're really using the cisplatin-based regimens. And then the most recent of the Norwegian studies showing that it is related in part to the dose. The higher the dose, the higher the risk. This is a really nice study that's just published this year from the Dutch group, and they looked at the onset of traditional cardiovascular risk factors in men that had survived germ cell tumor treated largely with bleomycin, etoposide, and cisplatin. And so what you see here is an increase in hypertension fairly rapidly, lipid disorders, and obesity. And what they did is they compared this to the general population. They calculated the number of patients that had metabolic syndrome, and they found it was a little over a twofold increased risk for these still relatively young men compared to same age matched controls, and that the men with metabolic syndrome had increased carotid intima-media thickness measurements, which is a good measure of endothelial dysfunction. You're already on the pathway of atherosclerosis, and that the metabolic syndrome was also associated with lower testosterone levels. So you've got a male that's been treated with chemotherapy, had an orchiectomy, he has other things that may affect his gonadal function, and a lower testosterone level in the general population we know is similarly associated with metabolic changes. So this has gotten us thinking a little bit of what happens in this process. And this is the general population. This is you and me sitting here. This is not talking about cancer survivors at this point. But let me walk you through this busy cartoon. The central part, what many of our cardiologists and epidemiologists think is our deep organ fat, that around our liver, around our deep organs, which we refer to as the visceral adipose tissue. It is more unhealthy than my side saddles or my thigh fat that is our subcutaneous stores. And you start into this inflammatory cycle where you have your increased adiponectin and your TNF-alpha that are starting to irritate to cause inflammation along the endothelial lining, causing your endothelial dysfunction, which starts the progression towards atherosclerosis, all the while setting up an inflammatory cycle with a fatty liver, also starting with your insulin resistance, and then ultimately leading to a premature coronary artery event. So we know from studies, and still woefully understudied, but both cisplatin and indeed even bleomycin cause direct damage to the endothelium. So the question is, does that 3-month course of cisplatin with that damage to endothelium, does that make a difference? Is it something that the body recovers, or is that seminal event then something that then leads on to the development of visceral adiposity, not the direct, not the direct irritation here, but the other changes. Remember, these men going through chemotherapy lose muscle mass. We replace it with fat-free mass. And we have a higher prevalence of visceral adiposity that's leading to those other parameters that I just showed you. There are lipid abnormalities, elevated triglycerides, increased LDLs, low HDLs, elevated C-reactive proteins, and eventually their insulin resistance. And within this milieu, if you will, is there hypogonadism. So you have both a direct insult and then kind of a little smoldering fire afterwards. So these are mechanisms that remain to be further elucidated. We're actually doing a study right now. We're looking at endothelial function pre-post cisplatin administration with each dose and comparing those same outcomes with our surgery-only patients. So back to our chart, and if I talk about secondary neoplasms, I'll remind you that 16% of all cancers diagnosed in the U.S. are actually a second or a third or a fourth cancer. So regardless of the treatment exposure, just sometimes because of our genetics, because of our lifestyles, because of factors we don't understand or interaction between any of those, most of our AYA patients have a reasonable increased likelihood of having a second cancer sometime during their life, a second primary neoplasm. But the model for this is our patients with lymphoma. This is data that we recently presented and have analyzed and in review, where we looked at the Hodgkin lymphoma patients. So this, again, is your adolescent extending into your young adult patients and the childhood cancer survivor. And we actually had raw data from colleagues' study that's led at Sloan Kettering by Joni Bernstein, the WeCare study, where we had the cumulative incidence of BRCA1 carriers. And you can see, even a first-year medical student can see the similarity between these and the very significant difference from the general population. By age 50, over 1 in 3 of the women treated with Hodgkin lymphoma. And that's some of our older therapies, although I'll tell you that as we look at our newer therapies, it's not that much better. And I'm not going to go into detail for the sake of time here, but comparable to what we see in our BRCA population. And we know the higher the dose of radiation, the higher the risk. And if we take the old mantle fill that our Hodgkin's patients received back in the 60s, 70s, 80s, on into the early 90s, and we decrease the volume of that to a mediastinal dose, we decrease their risk. We're not sure if we decrease it for a lifetime or we just simply put it off for 5 or 10 or 15 years. I suspect we're still well above the threshold from what we have seen. And interestingly enough, our therapies both elevate but sometimes decrease risk, and it's that interaction that's key. Because if these women also have radiation to the ovaries, and for the young adults, Lois Travis did a really nice study. If you look at women that had Hodgkin lymphoma that are in their 30s and had high-dose alkylating agent chemotherapy that also affected their ovarian function, and you decrease their estrogen exposure, you see a decrease. So you've increased and then some reduction in risk. Now, this is one of the late effects that age really makes a big difference. The younger, the higher the risk. By the time you're around 35, that risk pretty much has plateaued out, both in terms of relative risk and absolute excess risk. So many of these women that have breast cancer following their radiation to their chest for Hodgkin lymphoma have their diagnosis at a young age. The interval is usually 10, 15, 20, 25 years, just like the general populations, the upper outer quadrant. And not surprisingly, because the radiation is uniformly distributed, we see a very high proportion of these women having bilateral cancers. I can't tell you how many pathology reports I've read of a woman having ductal carcinoma in situ, having a lumpectomy, 2 years later having invasive cancer and dying metastatic disease. It's just overwhelming how frequently we see bilateral disease and the need to be very proactive with that. Because when these women are diagnosed at a young age, at an early stage, they do quite well, just as well as the general population. Their hormone status is no different than the general population. And they have limitations in their therapy because they've already had radiation, and often they've had anthracyclines, and the additional use of doxorubicin-based chemotherapy for the breast cancer markedly elevates their risk for heart failure. We published a systematic review that went over this in great detail for those that are interested, that talked both in terms of the risk, the outcomes of this populations, and then the harms and benefits associated with breast cancer surveillance. Patty's going to talk more about surveillance later. I won't talk about it any further, other than also just to highlight we've got our first publication with the International Harmonization, I can never remember it right, Melissa, International Harmonization Group for Guidelines, something of that nature, but it's a multi-country effort, and we have a paper looking at our international recommendations for breast cancer screening for women that are adolescent or young adult, so going up to age 30, the time period that the radiation exposure is critical. And then some really nice studies, and you're going to see a growing number of studies here, looking at what genetic factors predict radiation-related risk, or what genetic factors predict anthracycline-related cardiomyopathies, or what genetic factors predict cisplatin-related ototoxicity. Tim Best and Ken O'Neill and their group at University of Chicago did a nice study of identifying 2 variants within the 6q21 gene that were associated with second cancers. And then our Dutch colleagues, again, doing a really nice job looking at a high-risk profile. So here's identifying a particular SNP, and here really looking at an array approach. But in the not too distant future, that's information that may help us. And in fact, I mentioned ovarian radiation, I mentioned alkylating agent chemotherapy. You could think about family history, how does that play a role in it? So there is a whole host of both treatment factors, our traditional risk factors, and maybe other things that tie into their estrogen exposure. And so we have a group at Sloan Kettering led by my colleague Chaim Moskowitz, where we're creating a breast cancer risk prediction model. And obviously the intent of that is to be able to introduce our work in the gene environment too, to see how that modifies or affects their risk. Who's at risk for infertility in the AYA population? In one way or another, really most subpopulations, obviously, not all cancer groups. And when we say infertility, it's much more than infertility. I talked about second cancers and cardiac disease in the first part. That's what keeps me awake at night worrying about my patients, making sure that if they're going to have something, we can either detect it or prevent it that would shorten their life, to keep from shortening their life. But infertility is the #1 issue of our patient population because it ties into their body image, their sense of self-worth, their gonadal function that has to be replaced. There's so much that gets tied up into this area. So I'm going to feature one paper that I liked this paper. It's a paper published in Cancer last year, and it's looking at women that are in the AYA, the 15 to 39, and it looks at 5 different groups, and it looks at those patients having acute ovarian failure after chemotherapy related to their age of diagnosis. So you see the women that were closer to menopause. Menopause normally is at age 50 in our country. 40 would be premature. So the women that are moving towards that way, they get their high-dose alkylating agent chemotherapy, and they go into acute ovarian failure. This figure shows their infertility despite having menses resuming after the chemotherapy. You see, it's pretty significant. For a woman that's treated at age 35, almost 1 out of 2 are infertile after that. And as we see in our country, so many of our women moving the timing of their planning their family, this is obviously a quite important issue. And then early menopause, so the flip side of the acute ovarian failure, and not surprisingly, those women that are treated at a younger age with high-dose alkylating agent chemotherapy are at higher risk. In fact, this is actually fairly straightforward in a clinical sense, as our alkylating agent chemotherapy and radiation to the gonads are the really important aspects. And then our patients that go through the stem cell transplant really take a beating with respect to gonadal function, fertility, etc. The last one example that I'm going to use is just multiple conditions, and I'm going to pull out our leukemia patients that go through an allogeneic stem cell transplant. And remember, they sometimes have had their prior therapy, their preconditioning therapy prior to their transplant, TBI, or if they go through a chemotherapy-only preconditioning, and whether or not they develop both acute or chronic graft versus host disease. And this is actually a very substantial portion of the patient population that we follow. And these are not things that you might have. Literally every woman treated with TBI during her adolescent, young adult years will end up having this group. Hypertension comes on later, but they all are thin. They've lost all of their subcutaneous fat. They have increased visceral adiposity. Their BMIs are low, so it's a thin fat picture, if you will. They all become insulin-resistant lipid disorders, fatty liver, and what, of course, we're trying to prevent is the progression to coronary artery disease. But you have a whole host of things. And so when you're thinking about economics earlier, when you're thinking about healthcare utilization, this gives you where those dollars are being spent. Somebody going in for multiple visits for multiple conditions, paying for medications for multiple things at a young age, where most young adults are not paying for any type of medication, much less even going to the doctor. So to put that into context. So I'm going to leave you with one final story. A lot of times when we present this data, people say, well, that's our old therapies. We're doing a much better job. So I'm going to use an anecdotal experience. I'm going to wrap it up. This is Lorraine and Lauren. Of course, I have permission to give this, and they, in fact, love showing this story. Lauren was treated as a young adult Hodgkin lymphoma patient back in the early years of Hodgkin lymphoma therapy, 1975. She is treated with high-dose radiation to the mantle field, her chest area, and 36 gray to the abdomen, to the periaortic. She had thyroid cancer at age 51, 2-vessel coronary artery disease, bypass at age 53, breast cancer at age 55, multiple basal cells. She's asplenic. She has diabetes, fatty liver, lipid. Now, this is a great example, as this is not all late effect. You saw the picture. This is a wonderful Italian family that celebrates by eating. They go through stress by eating. The grandmother's skinny, and she brings out these big things of cutlets all the time. So this is a classic example of somebody's genetics, their lifestyle exposures, and their treatment exposures. But a wonderful showing of the different chronic conditions we might see. And here's Lauren. Lauren at age 15, again, a AYA patient diagnosed with Hodgkin lymphoma, treated with our more contemporary therapy, lower dose radiation to the involved field. So we shrunk down the volume of her radiation, lower dose to her periaortic, Viacop, and she ends up from her Viacop with myelodysplasia, and infrequent, but definitely occurs, went through a transplant. So she has ovarian failure, she has vascular necrosis, hypothyroidism, insulin resistance, iron overload. But what I will tell you is that both of these women have absolutely wonderful quality of life. Lauren is a nurse that works at the breast center right where we're located. So there remains an urgency for us to understand, to predict, to prevent, and manage late effects of the AYA cancer population. So I'll leave you with this. Melissa's going to go into future directions in much greater detail, but this is where we need to be moving. We still need better estimates. I don't know that we've had anybody talk about one of our gynecologic cancers yet today or tomorrow. Still woefully understudied population, both cervical and our ovarian cancers. So we need better estimates across all cancer groups in the AYA population. And we've moved well beyond estimates too. We need to understand why these occur, understand the mechanisms so we understand how to prevent them. I'm always highly respectful of my oncology colleagues, and especially radiation oncologists. They feel like they just get the brunt of all of our talks. I always remind our patients that it was the radiation that actually cured them so that we could have the conversation we're having. And I think our patients well understand that. It's a moving target. And then we're starting to get some gene studies. We have some exposure studies. We understand a little bit of the interaction of lifestyles and exposures, but this is where we're really going in the next 10 years as we look at those interactions so we can really individualize our follow-up care as well as our upfront therapy. And then working on risk prediction and risk stratifications and obviously interventions. And with that, I'll thank you for your attention and entertain questions when we're done.